Well, thank you so much for inviting me to speak today. I hope that this all works and you can hear me clearly. If any time along the way you can't, please stop me. I can't hear you talking very clearly, so if there's any questions, I may need you to repeat it into the computer for me, please.
Yeah, no problem.
All right, so we'll get started. So I hope that you found this talk interesting and informative today. I'm going to talk to you about nutrition and food for neuroendocrine tumours. There actually hasn't been a lot of information published for nutrition to do with neuroendocrine tumours. There's been a couple of articles come out in the last 5 years or so, but unfortunately nothing too significant, nothing different from what we've known before, but it has affirmed we're all on the same page. So hopefully in the future there will be more papers published on different aspects of nutrition for NETs. So today I'm just going to have a very brief overview of what are NETs and just to relate it to nutrition. I'm sure you all know plenty about that anyway. I've been asked to speak about diarrhea, so that's my main focus today. Diarrhea and the different causes of diarrhea. I'll speak about carcinoid syndrome, fat malabsorption, and pancreatic enzyme replacement therapy. I've also been asked to mention constipation, so we'll chat a little bit about that. I'm going to mention some micronutrient deficiencies and cancer diets, which is something that just comes up with many of my patients, NET or not. So what are NETs? They're hormone-producing tumours. Some are functioning, some aren't. The functioning ones actually produce different hormones which circulate around in your body. And the symptoms depend very much on the type of NET, what hormones are produced, as well as the extent of disease. They are predominantly found in the gastrointestinal or respiratory tract. However, we do know that they are found elsewhere as well. Most NETs are generally slow growing, and they are often only discovered once they've spread, which is often to the liver, especially with the gastrointestinal NETs. So the more tumours that are in the body, that means that there's more hormones being produced and therefore more symptoms if it's a functioning NET. Okay, so what can cause diarrhea? We've got lots of different causes, and I think if you are experiencing diarrhea, it's really something that the team needs to investigate, get to the bottom of the cause of the diarrhea, because if we're not treating the correct cause, then it's not going to resolve the problem. So surgery, some medications can cause diarrhea, such as antibiotics and somatostatin analogs. The hormones may be causing diarrhea, especially for carcinoid tumours, which are serotonin producing, lipomas and gastromas. Diarrhea is a side effect of all of those hormones. Bacterial overgrowth is something that can cause diarrhea, as well as infection, which is like a gastrointestinal bug. And what happens is all of these lead to malabsorption of some sort. So the food's rushing through your gut, the nutrients are not broken down or absorbed into the body, and therefore come out pretty quickly. Okay. So first we'll discuss surgery. The diarrhea depends very much on the location of the surgery and how much bowel has been removed or what organs have been removed that may be affecting or causing diarrhea. The pancreas and gallbladder may induce diarrhea if resected. And as I mentioned, that causes malabsorption. Sometimes if it's because there's a big chunk of bowel that's been removed, it's because some of the nutrients are not able to be absorbed at that point in the gut anymore. And it may take a while for the gut to settle and adapt, sometimes up to a year. So directly after surgery, sometimes people may initially require some artificial feeding in hospital, either IV or parenteral nutrition. nutrition. Some people know it as TPN. Others may just require a chew directly into the gut and they're given liquid nutrition. And others may be able to progress slowly from a liquid diet onto a light, regular diet, and probably require low fiber after surgery for a couple of months, just to allow the gut to heal and adapt. But that shouldn't be a long-term thing. Okay, so diarrhea can also be caused by medication. So we know that antibiotics upset the bacterial balance in our gut, and that can lead to some diarrhea. So if it's due to antibiotics, it's important to make sure that you remain hydrated. You might need some electrolytes with your hydration. And if it's a long-term antibiotic and the diarrhea is very severe, then the doctors may have to consider changing the antibiotic, or just have to power through that. Somatostatin analogues is the one that's particularly pertinent to NET patients, and that's a sandostatin LAR, so the monthly injection that's given. We know that this injection has so many benefits for NET patients. Initially, it was used to block the release of the hormones to reduce symptoms, but recent studies have shown that actually the injections or the octreotide helps to stabilize disease. It controls the growth of tumour. So you get immense benefit from these injections. However, one of the side effects is that you may experience fat malabsorption, because what it does is it blocks the pancreas from producing the little enzymes that digest your food. I'm going to go into more detail about fat malabsorption and how to correct it in a few slides, so I'm going to leave it there for now. One is diarrhea from infection, and that's usually if your immune system isn't good or if you've been traveling, but with that you usually get a sudden onset of fever, and the doctors can determine whether it's infective by taking a stool sample. If it's positive, then they'll give you antibiotics, and it's just important to stay hydrated with fluid and electrolytes, and ensure that you're just having very bland foods for a little while until things settle down. But that should only last for a few days, whereas the others are all much more long-term. We also have diarrhea from bacterial overgrowth, which is something that is being studied by a dietitian colleague of mine in the UK. And they are finding that small intestinal bacterial overgrowth is a bit more common in NETs than we thought initially. And basically what this is that the good bacteria are usually in your colon. And sometimes if things are not working properly, or if you've had a lot of surgery, the bacteria may migrate up into the small intestine. And that can cause a lot of cramping or wind after eating. Sometimes a bit of fat malabsorption may be observed. And if we've checked the regular causes for diarrhea or fat malabsorption and that's not working, then it's worth having a look into bacterial overgrowth. It's diagnosed through a breath test, and I know here in Australia, it's actually, you can't do this through Medicare. It's a privately funded breath test that you do with hydrogen or methane. And when I've spoken to doctors about it, they've actually said, well, let's just skip the breath test and go straight on to the antibiotics. If it improves, then we know what it is. So that's something that you could look into in New Zealand, but I suspect it's probably a similar situation. What the UK group are having a look into is whether, if the antibiotics don't work, or if the doctors are not keen on giving antibiotics, because it's quite a long cycle of, I think, 3 different antibiotics, then you may be able to try something called a low FODMAP diet, which should be done under the guidance of a dietitian. it's an exclusion diet where you cut out a whole lot of food for 4 to 6 week period, and then you reintroduce them slowly. And that may be done in conjunction with probiotics. As I said, the evidence with regards to that is not really available at the moment, but that's a work in progress. As we know, many people with NET experience diarrhea from the circulating hormones in their body. So the hormones are released by the NET, and they cause an accelerated bowel motion, which doesn't allow the nutrients to be digested and absorbed, and therefore results in diarrhea or a malabsorption type of diarrhea. You also have some, or most of them, are increasing secretions within your gut as well. So that causes the bowel motions to be a lot more watery as well. And this type of diarrhea is usually treated with somatostatin analogues, or sandostatin or octreotide LAR. Okay, so diarrhea treatment. This is a bit of a can of worms, and it's something that your doctors will need to decide on. But many people with uncontrolled diarrhea may need to take a pyramide. Here it's known as Imodium or Gastrostop. They may need to take it frequently during the day, and that depends on what your doctor has prescribed for you. Codeine is another medication that helps to slow the bowel down, and it's also commonly used for people with uncontrollable diarrhea. Cholestyramine is more to do with if the gallbladder is being removed, or if there's a problem with the bowel, the cholestyramine helps to absorb bowel salts. That one's not used as commonly, and I believe it's not very nice to take. So that's a tricky one. You've got pancreatic enzyme replacement therapy, which is known as Creon. There's also, I think it's called Pancrex as well, but Creon is the most common one, and that's the one that's an international brand. And that is replacing those little pancreatic enzymes that are no longer being released by the pancreas because it's been blocked by the somatostatin analogues. So from a nutritional point of view, we were looking at the type of fibre in your diet. So we know that insoluble fibre or roughage, like skins and seeds from your fruit and vegetables, nuts, just little seeds like pepitas that you may eat, those have a hell of a lot of insoluble fibre, and it's not digested. It goes right through your gut. So we know that can actually irritate the gut if it's very sensitive, and therefore should be avoided for a period of time. Soluble fibre, which is found in oats, and then the flesh of fruit and vegetables, that tends to have more of a binding and bulking up effect. So that may be a good source of fibre to have, because it can help hopefully bind up the stools a little and make them less loose. It's also important to avoid caffeine and alcohol, as these are bowel stimulants. So if you've already got things rushing through your gut, caffeine and alcohol is just going to make it worse. I'm not generally anti these foods. It's more just as a guideline for people with diarrhea. And many people find that there are individual foods that will not suit them. So in that case, it's important to avoid those foods for yourself, but it's not generalized across the population. All right, so carcinoid syndrome is a collection of symptoms which is resulting from an excess of hormones such as serotonin, histamine, somatostatin, and chromogranin A, and it's produced by the NET. So the symptoms are flushing, diarrhea, wheezing, colicky, abdominal pain, carcinoid heart disease, and pellagra, which is a niacin deficiency. The reason that you may get a niacin deficiency is that niacin is produced from tryptophan. And what actually happens is that the serotonin actually uses up tryptophan, just to put it basically, so your body's unable to then produce the niacin. So there was a dietitian that was in the United States, like Monica Warner, and she released some info. It wasn't published as such in the journals, but she released an observational article about triggers for carcinoid syndrome. So she just spoke to many of her patients, and they sort of gave her a list of things that may exacerbate their carcinoid syndrome. So stress was at the top of the list. From a dietary point of view, large meals often affect carcinoid syndrome. So people describe having flushing and diarrhea after having large meals. Fatty foods, spicy foods, caffeine, and alcohol may all be stimulants or triggers for carcinoid syndrome. It's a very individual thing, so it's not to say that you should avoid all of those if you do have carcinoid syndrome, but it's good to be aware of them so that if you've eaten something on that list and you develop the syndrome, then you know, oh, it might actually be due to that food, maybe I should avoid it for a while. There's also a lot of talk about amine-containing foods being a trigger, and I've had some patients put onto amine diet by doctors. The important thing to remember is that not everybody reacts to amine. So it's important that you're only avoiding foods if you need to. If the amines don't affect your syndrome, there's no need to avoid the foods. So some amine-containing foods would be aged and fermented products, like protein foods like aged cheese, smoked or salted meats, fish and yeast products. So the processed meats are usually high in amines. And just I feel it's important to remember, although I don't know if everyone's using the urinary 5-HIAA test anymore, but if they are, there's quite a list of foods to avoid, and it's important to know that these do not actually affect your disease. It's only important to avoid these while just before and during urine collection, because the byproducts of some of those foods may give a false result. So it's more to do with the byproducts rather than those food actually affecting the syndrome or the disease. Oh, sorry. Okay, so I'm going to just talk about fat malabsorption shortly, but in order to do that, I just wanted to give everyone a brief idea of digestion and absorption so that you can understand better what's happening when you have fat malabsorption. So initially, when you eat your food, the first part of the digestion process is chewing. And your salivary glands produce amylase, which is the first little enzyme that helps to break down the carbohydrates in food. So all of your foods will be carbohydrate, protein, and fat. So we've got the first bit of carbohydrate being broken down. Then as it goes down into your stomach, we have some more enzymes being produced within the acid, the stomach acid. We've got pepsin, which digests your protein. And we've got the stomach acid activating your enzymes and also breaking up the food. Then as the food travels down into the top of your small intestine, which is your duodenum, that is when the pancreatic enzymes are released. Now these pancreatic enzymes are enzymes for breakdown of carbohydrate, protein, and fat, but it's the first point at which fat is digested. So that's important to remember. So we've got peptidase for protein, sucrase for sugars or carbohydrates, and amylase for other carbohydrates. Okay, so there's a few causes of fat malabsorption. It may be pancreatic insufficiency, which is due to a tumor in the pancreas, or pancreatitis for some people. It may be due to surgery. A Whipple's procedure and a pancreatectomy are where they remove part or all of the pancreas. Usually they try to preserve some of it, but many times, especially if the head of the pancreas has been removed, it does affect the function of the exocrine function, which is producing the enzymes to break down food. And you've also got your somatostatin analogs, which, as I explained, block the enzymes from block the pancreas from releasing the enzymes. So some of the implications of fat malabsorption would be weight loss, because you're not absorbing a lot of the precious nutrients that you're eating. You may also end up with vitamin deficiencies, and this is due to some of the vitamins being fat soluble, so that's vitamins A, D, E, and K. And you may also be missing out on some essential fatty acids. How do you know if you've got fat malabsorption? Well, number one is the stools. So it's called steatorrhea, when you have very pale, floaty, oily stools. Difficult to flush the toilet, you have to flush a couple of times. And it's important that if you do notice that you discuss it with your doctors. We also see with malabsorption, people get a lot of wind and bloating and cramps after eating. So this is the case. It's quite an easy fix as long as we pick up on it, and the doctors can prescribe some pancreatic enzymes for you to take with your food. So Creon and Pantrat are the ones that are available in Australia. Many people are given a protein pump inhibitor, so that's for usually used reflux, and that helps to ensure that the enzymes are not prematurely activated. We judge the amount of Creon that we need by the fat content of the food or the meal. So even if you start taking Creon and you notice that you're still having those bowel effects, it may just be that you're not taking enough Creon. So don't give up on it yet. Rather speak to your doctors or dietitian and try and increase it before stopping completely. We know that it depends on the amount of fat in your diet. So if your diet is generally low fat, then you probably won't need much. But if on occasion you go and eat out and you might have a pizza or fried fish and chips, on that occasion you probably need an extra Creon capsule with that. You don't need to take any with fat-free foods, such as fruit or fruit juice, tea and lollies. It's really important that you take your Creon at the correct time. If you take an hour before meals or an hour after meals, it's not going to do anything. You're wasting your money with the enzyme. So it's really important you take it with your meals, usually with the first bite. Some people like to take one with the first bite, one halfway through. They generally last for about 40 minutes in your gut. Then they stop working. So if you having a long drawn out meal, then it's good to sort of space them out through that meal. So one with starters, one with mains, and maybe an extra one with dessert if you usually only take two. There is some thought that alcohol may interfere with that. So it's important to just see what happens. If you're having alcohol with a meal and you're fine afterwards, that's great. If you notice that your bowels are not so good afterwards, then it may be due to the alcohol. So just keep an eye on that. Generally, we start people on Creon, the 25,000 unit capsules. And I would usually, as a standard, start people on 2 with meals and 1 with snacks, and then monitor the symptoms and increase accordingly. So that's a good idea. Some doctors use much lower dose capsules, the 10,000 units, which are not really worth it. And some people just say start with one at each meal. So it depends on the size of the meal and the amount of fat in it. Okay, so I'm just going to move on now to constipation. Some people experience constipation after some of the treatments, I believe after the PRRT, and also many chemos cause constipation as well. So the definition of constipation is that bowel motions are difficult to pass and are infrequent. And it can lead to a lot of pain, bloating, and discomfort. And a lot of people lose their appetite when their bowels aren't opening. There's no desire to eat, so that's not a very good thing. So from a dietary point of view, it's really important to have plenty of fluids and a high-fiber diet, which will help to bulk up and soften the stools. So fiber is found in your whole grain carbohydrates, nuts, seeds, legumes, and pulses. We should be aiming to have 2 fruit and 5 vegetables a day. That's according to the Australian dietary guidelines. And some people find that stewed prunes or pears do help a little with relieving constipation. Unfortunately, if constipation is caused from drugs, it's more often likely that you are going to need drugs to help open your bowels. And that's okay. I think it's important to speak to your doctors or nurses about that and ensure that you are given some laxatives or something to help open your bowels. And it's also really important to remember that you should be taking it regularly, not waiting until you're struggling to open the bowels. So, find a daily regimen of what you can do to help with your bowels opening daily. We know that physical exercise, physical activity is really helpful in getting the bowels moving. So if you are physically able to do that, then you should be exercising too. And there's many other benefits to exercise as well, which I'm not even going to touch on today. So lastly, I just want to, it's not lastly, second last thing, we're going to talk about micronutrient deficiencies. We know that serotonin producing tumours and for carcinoid syndrome, that niacin is a problem, as I've mentioned before, so that's vitamin B3, vitamin B12 and vitamin B, also routinely supplemented. So many patients are given a vitamin B complex. Can everyone hear me okay? Because I've got a bit of insulin. So for those who have had fat malabsorption for a period of time before it's corrected, it's important to check your fat-soluble vitamins, A, D, E, and K. I think vitamin E is quite difficult to be checked. I think they have to send away to the States for that one, but at least the other ones should be checked via a blood test. For people with chronic diarrhea or following gut surgery or malabsorption, we know that magnesium, copper, thiamine, and pyridoxine and folate may be deficient. So again, if you've had a lot of watery diarrhea for a period of time, it's good to have these nutrients checked via blood tests. And just as a general cancer deficiency, we often find selenium is a problem. So another one to have checked. Lastly, I'm not going to go into too much detail about this in the interest of time, but most cancer diets are very restrictive. They don't have enough scientific evidence to back them up, and people often end up missing out on essential nutrients. So what I'm going to say today is just, if you are looking into diets on the internet, which sometimes it's better not to read too much, then just make sure that you're discussing this with the dietitian or a doctor or a nurse and try and ascertain whether it's actually something worth doing. More often than not, the answer will be no. And it's more about your individual tolerances and preferences rather than following general cancer diets. We know that NET are very different from other cancers as well. So it's really important that when you are reading on the internet, you're using trusted information sources. So you've got the Unicorn Foundation website, the Cancer Council Australia website is very good for general cancer advice. The Net Patient Foundation is the UK charity that I was working with, and they've got some dietary guidelines as well as others, just keeping in mind with that that obviously the treatments available in the UK might be different from what's available in New Zealand. And there's also Macmillan and Cancer Research UK, which are other websites that, if you're just looking for general cancer information, those are trusted websites.